So first, thank you for having me here. Great morning to talk about DADA2 again. So I'm going to talk just about our nationwide multicenter study on DADA2, which was a simple study just to retrospectively analyze patients with DADA2 in Brazil. I'm not going to go deeper into the physiopathology of the disease, as we have many discussions yesterday, if the endothelium is involved or not, if it's interferon signature a consequence or a cause of the disease. But we have a huge problem because it has a broad spectrum clinical manifestations. So different specialties, medical specialties can see these patients, and we are not recognizing these patients in Brazil. Mainly because we don't have great access to the genetic diagnosis in our country, so it's been a huge problem for us in Brazil. So data from autoinflammatory disease in Brazil are really scarce. It started with Adriana de Jesus, that is here at NIH now, in 2012. She did the first multicenter study in Brazil, but she moved to NIH, so she's not back in Brazil. And then we started, after I returned from Italy, when I was with Professor Gatorno, to collect patients from all over Brazil to have data of these patients in our country. So this work, what we did, we used our network in our Center of Rare Disease and Rare Immunological Disease in the places where I work, which is the University of São Paulo. We have an ambulatory there just for autoinflammatory disease, and also in the Hospital 9 de Julho, which is a private center, so public and private centers, to collect patients with DADA2 from all over Brazil. We also used the network of the Brazilian patients organizations for autoinflammatory disease to have any patient that we have missed. And we used this platform of the Brazilian Network for Inborn Errors of Immunity, that is COBAY, is coordinated by Professor Magda, a enormous pediatric in our university. So what we basically retrospectively analyzed the data on clinical, genetic, and therapeutic options of these patients in Brazil. What we found is the first thing is we found 18 patients, which is almost nothing compared to our Brazilian population. We have like 220 million patients in Brazil, so we have just 18 patients diagnosed until now, which is really nothing. So we are missing a lot of patients with DADA2 autoinflammatory disease and also DADA2 in Brazil. Mainly, almost all patients are in the southeast region, which is the richest part of Brazil. And we have 3 patients here in the south, represented by my friend Fabiano here also. And we have some small number of patients here in the northeast of Brazil. But the north and the middle of Brazil, we have no patients diagnosed with DADA2, so we have to work on disease awareness in this part to have more patient diagnosis there. Luckily, the median delay to diagnosis is not that longer for DADA2. It was 5 years, but we have some families with 70 to 20 years delay of diagnosis, so we are diagnosing patients also in the adult department, just not the pediatrics. Which is very interesting too, because Brazilian has a lot of admixtures and also consanguinities in some small countries in Brazil. But I think that's only 60% of them were homozygous, which means there was not just consanguinity involved in the development of this genetic disease. So it is very interesting. The most common mutation we found in our country are these 2 mutations, actually 25 to 25%. The 453 and the 973. We have a mix of these 2 mutations. We found 2 patients with 2 novel mutations here, a huge deletion, and another patient with 276. So we performed the Western blot to DADA2 to confirm that it was really a novel mutation. And both patients have had absent levels of DADA2 on Western blot. Not just one, it's wrong here. We had 2 patients that came to us as an interferon-mediated disease, so we performed the interferon signature because we thought it was a really interferon-mediated disease, and they have the positive interferon signature, but which is curious because it's not a high score as the other interferon-mediated disease. They have like a median score, just 8 to 10, and the others like 100 to 200. So it's maybe this can be another sign when we found these patients with interferon signature in our country. The phenotypes is what 50% of them had the classical stroke or the polyarteritis nodosa, so 50% of them are clearly the classic phenotype, but 50% I decided to call them like OBS-like phenotype. That's because that's why we immunologists recognize these patients in our daily clinic. So 50 of them were in the other phenotype, let's say like this. One patient had a pediatric lymphoma at the age of, I think, 4 years. So he was diagnosed later, very many years later before. One patient had bone marrow aplasia. It was a very complex patient from the Ribeirão Preto, not from our hospital. 2 patients was labeled at CVID. One had a stroke, but it was not completely was not recognized as a possible DADA2. It was treated as a CVID. And 2 patients that is followed by Fabiano was diagnosed as antiphospholipid syndrome. They just had at the beginning polyneuropathy and also the levedo reticularis. So we have many different diseases that we have to work on to have the diagnosis before. Which is very interesting too, is because at that time we had this multicenter analysis, 50% of the patients also had disabilities. So which is very interesting that, as Professor Gatorno was talking now, should we do the diagnosis of this patient when they already have a disability, or should we do the diagnosis before? Because this is very complex for them later in life. So many were with intellectual disabilities because of the number of strokes they had. I'm not going to go deeper on these two. Some of them have a severe diplopia. I think it is in English too, the same name. So this was severe disabilities. And some patients, a lot of patients actually, not some, they had sensitive and motor polyneuropathy. So then we have a lot of disabilities in patients with DADA2, I think all over the world, but also in Brazil. We found 2 patients unfortunately died at the end of this retrospective analysis. One died of infection, and I think it's because of and this is the one who had lymphoma at the beginning of life, and it probably is because of the high immunosuppression he had all over his life. It's not consequence of the disease. I think it's a consequence of the treatments he got all over his life. And another child died of hemorrhagic stroke, very severe hemorrhagic stroke. So 12% rate of death in our cohort in Brazil. Which is curious because I asked all the physicians that participate into this analysis, what was the treatment they used as acute treatment for the disease when they are managing their patients. What's curious is that 1/3 of them did not have a good response to corticosteroids. So some patients also did not have a good response as they were treated as vasculitis, let's say something like this. So we really need to think about what to do in acute manifestations of DADA2, not just HL8, as Professor Gatorno was telling here, but also some other manifestations. What can we treat? We did not find anyone who used plasma as a possible therapeutic option in Brazil. Curiously, one patient had a beneficial response to mycophenolate. It was the patient with the HL8 phenotype with bone marrow aplasia, HL8 phenotype. It was a confusion on the diagnosis, but was this patient. He had high levels of double negative T cells, so that's why we decided to add mycophenolate, and it really worked for this patient. She's doing pretty well on mycophenolate. Another interesting thing is because all the patients that were labeled as CVID, they were on chronic infusions of immunoglobulin, and it didn't prevent the occurrence of stroke and other manifestations. So I don't think a VIG can treat or prevent any kind of immune or dysregulation in this patient. So I think it's something that we have to work on too, because there are some conflicting informations in the literature. Some people say that it may work. what happened is that 100% of the patients were on anti-TNF, different anti-TNF in Brazil. We have difficult to say, like, use this or this anti-TNF in our country because each patient got a different access to treatment there, but 100 of them were on anti-TNF, and all of them had a great response to anti-TNF. Of course, we cannot say what is a great response to anti-TNF because we don't have how to measure this is working, this is not working, but at least based on what physicians say there, like it is controlling them, it's not controlling the disease. They say that the disease is controlling under anti-TNF. We are working now on a WhatsApp group to see, that's very interesting because we have high incidence of tuberculosis in our country. So we were just talking to make like a survey using this database to see the outcomes of tuberculosis in these patients. If we have, I don't think we have any tuberculosis, not positive PPD test for these patients too. So at that time, my conclusion was that we should have consensus to diagnosis and treatment. I agree with Paul because we're having a huge problem with patients with heterozygous mutations in Brazil. They are coming to us because they want to be treated. Some of them want to have bone marrow transplantation, something like this. So we should have care in the way we use the scientific information when we are not sure of the real pathogenicity of the heterozygous patients. So we really need the consensus, so everyone should talk the same thing in the same language in everywhere. And we also need to take action in Brazil to change some things because autoinflammatory disease doesn't exist for the private nor for the public systems in Brazil because it doesn't really exist. People are using different CID codes to treat them, like seronegative arthritis and something like this, which is a nightmare. So it's not. We have to work on it to create real data to show the real world, and that's why I'm going to show our project with France that calls OBRAFRA. It's a project we are working with the University of Paris Institute of Medicine with Marie-Louise Fremont, I'm a friend. Brazilian health friend, and the University of São Paulo and the Biomedical Institute with Professor Alessandra Pontillo, another Italian in my life. And we are going to use two groups that already exist. That is the Brazilian Network for Inborn Errors of Immunity, the Genome Rare project conducted by Bosco. It's an enormous project. So we took the advantage because we had, over the last 5 years, almost 700 patients sent to our unit to screen for autoinflammatory disease, and all of them were screened by the Whole Genome Sequence Program. So we have a lot of data to work now and to make some great job there. And we are working now in this cure periodique. I'm not good at French now, but I'm going to prove it. We are working on this translational immunology education program. So we are going to teach all the immunologists and rheumatologists. So we invite, I forgot this, we invite a immunologist and a rheumatologist from each country, each state of Brazil. So we're going to talk the same language. We are going to teach how to clinical stratificate, like phenotyping. We are going to teach them how to interpret genetic results to avoid this type of confusions with heterozygous patients, I hope. We are going to teach them on how to interpret and how to request immunologic data, immunologic tests, because it's expensive, of course, for everyone, not just for us. So we cannot spend, because we are going to do some other things that we have been doing over the last 5 years. That is the reanalysis of the genetic reanalysis, maybe work on specific pipelines for genetic reanalysis in our country, because we have some differences in our regions. I've been thinking, because HPO it's something very specific for autoinflammatory disease, and in Brazil it's very specific for regions, because fever in one region has one name, in another region has another name. So we may have a dictionary for autoinflammatory disease in Brazil, and we want to expand all these tests that we've been doing just for our patients, but to all over Brazil the next years. Of course, we are looking for a clinical trial for consensus on what we need or what we do, when we do, how do we do bone marrow transplantation and gene therapy for these patients in the future. In the end, we want to change the public publicity in Brazil for autoinflammatory disease, both for public, both for private. So thank you, grazie mille. My lovely professor, my lovely professor Marco Gatorno, who was the one who taught me, and I think that I'm following his steps, and I want to be someone like him one day. Okay. and and this is our team. My professor Jorge Khalil, he works on vaccines. I think someone you may know. My professor Tanya, and our team from the lab, and our team from the clinic of autoinflammatory disease. So I want to thank all of them because they worked for me to be here. So thank you very much.
Well, thank you very much, Dr. Mendonca. So I think we have a little bit of time for questions, if anyone has questions or comments for Dr. Mendonca. Yours, yes, please.
So I was wondering, how do you deal with the situation that you are probably advising patients to use TNF inhibition in a country where tuberculosis is, now I'm not sure if it's widespread, but how do you deal with that risk?
Well, we are following the Rheumatological Society recommendations to use anti-TNF. So we're screening them for PPD, or I think it's IGRA, the screening for tuberculosis. We do the X-ray or CT, depending on the situation, on the epidemiology of these patients. And if they have a positivity found in any way, like an image or in the skin test, we do the prophylaxis with isoniazid, I don't know. Isoniazid, yeah, for some months, so 3 to 6 months. So before starting the anti-TNF, and then we start the TNF. Sometimes, depending on the clinical situation, we do both together, but the toxicity is very high, so we don't want to do this.
Yeah, but how do you deal with the situation in your head that the patient might still afterwards contract tuberculosis?
Well, we follow the Brazilian recommendation because as tuberculosis is very endemic in our country, so we do the screening every once in a year at least. So, but depending on the situation, but for example, the contacts or where they live and where they work, we do every 6 months the control with the PPD or with the IGRA, depends on the development of these tests.
Yeah. Okay. Thanks.
You're welcome.
Please.
I will add, excellent talk, Leo. I will add to Joris about the use of infliximab in pregnant women in these cases because it's a formal contraindication to vaccinate. We vaccinate all in our countries at birth. Is by law. You get vaccinated with BCG and you have to formally contraindicate all live vaccines until the 6 months. So that happens from time to time when pregnant women come to the immunologist and they said, oh, my son was vaccinated with BCG and it's a mess.
Thank you very much.
Thank you.